Hello, my name is Patrick and I'm a Pulmonary and Critical Care Fellow. This video is on ventilatory efficiency. So when we're talking about ventilatory efficiency of the 9-panel plot, we are particularly focused on panels 4, 6 and 7. Now a quick reminder on the 3 vertical lines I want you to remember. We have 1, 2 and 3, and these vertical lines separate the different phases of the CPET test, and you'll see them in each of the 9-panel plots. Before we can talk further on ventilatory efficiency, let's just review the composition of our minute ventilation. So our minute ventilation is our tidal volume, which is the volume of a single breath, multiplied by our respiratory rate, which is our breaths per minute. Our resting tidal volume is roughly 10 mils per kilo, and tidal volume is actually composed of 2 different volumes. We have alveolar volume and we have dead space. Dead space is the volume of air that is inhaled during a breath that does not participate in gas exchange, i.e. it is wasted ventilation. This equation can be rewritten like this. Now our dead space is actually composed of 2 parts. We have anatomical dead space, which is our conducting airways like our nose, our pharynx, our trachea, our bronchi, where there's no gas exchange, and that is about 2 mils per kilo of ideal body weight, meaning in someone who is 75 kilos, they should have about 150 mils of anatomic dead space. The second component is our physiologic dead space, and that is air that reaches the alveoli, but there's no gas exchange, either because the alveoli are damaged or not perfused. So building on that, we can see why the composition of our minute ventilation helps us understand why it is more efficient for us to take deeper and slower breaths. In these 2 examples, we have 2 patients who are, say, 75 kilos and have 150 mils of anatomic dead space each. For example, one patient may have perfectly healthy lungs and the other patient may have a restrictive lung disease. Both of these patients are capable of reaching a minute ventilation of 6 liters a minute. The first patient by having a tidal volume of 500 mils and taking 12 breaths per minute. The second patient by having a tidal volume of 250 mils and taking taking 24 breaths per minute. What's different though is their alveolar volume. When you subtract their dead space from their tidal volume, the first patient has an alveolar volume of 350 mils, and when you multiply that by their respiratory rate, they have an alveolar volume per minute of 4.2 liters, whereas the other patient has an alveolar volume of only 2.4 liters. So despite them having the same minute ventilation, they have very different alveolar volumes. These are John West's lung zones. If you see at the top, we have a zone where there's a high VQ mismatch of 3.3, and this is where we have regional overventilation or underperfusion, and we're effectively wasting ventilation. At the bottom zone, where we have a VQ of 0.63, we have regional overperfusion or underventilation, and this results in impaired oxygenation. And then in the middle, here, we have a VQ of 1, and this is where we have nearly perfect matching of ventilation and perfusion, resulting in full oxygenation and clearance of carbon dioxide, where we have optimal efficiency in respect to ventilation and work of breathing. At rest, our dead space is typically a third of our tidal volume, but during exercise this decreases because of increasing tidal volume and pulmonary vascular pressures, and these increased pulmonary vascular pressures recruit more capillaries in the lungs, and this drops our dead space. And to highlight that, I have these 2 figures. So here we can see we have conducting airways and alveoli, and you can see this alveoli has a perfused capillary beside it, whereas this does not, and therefore this is dead space. But during exercise, with those increased right-sided pressures, this capillary opens up and there's increased ventilation of this alveoli, so the dead space ultimately reduces. This is the Bohr equation. Unfortunately, you need an ABG, but it's a ratio of dead space to tidal volume as a percentage of the arterial partial pressure of carbon dioxide. And what it looks at is the gradient between the partial pressure of carbon dioxide in the artery versus the partial pressure of carbon dioxide in the expired air. And so if the carbon dioxide in your exhaled breath is much lower than the carbon dioxide in your blood, it means you are diluting your breath with fresh air that never touched blood, meaning you have high dead space. Here we're looking at panel 6 again. We're looking at the slope of minute ventilation relative to VCO2, which is determined using linear regression analysis and can be conceptualized as the degree of ventilation required to clear a unit of carbon dioxide. Shallower slopes reflect more efficient ventilation and steeper slopes reflect less efficient ventilation, with the caveat that low partial pressure of arterial carbon dioxide during hyperventilation may also steepen the slope due to a reduced driving pressure for carbon dioxide. But the slope is essentially linear throughout the exam and reflects the overall ventilatory efficiency. Heart failure, COPD, pulmonary hypertension can all increase this slope. In chronic heart failure and pulmonary hypertension, the increased slope is thought to be because of increased VQ mismatching. There's adequate ventilation, but there's very poor perfusion. In chronic lung diseases, the increased slope is attributed to increased physiologic dead space. And here we can see in red a normal slope, and in blue we can see a slope associated with a disease, and that could be any of those that I just mentioned. Now we're looking at panel 4, looking at the ventilatory equivalence, another way that you can assess for efficiency. And instead of reflecting overall ventilatory efficiency like the previous panel, this panel reflects changes in efficiency over time. And it can be thought of as minute ventilation divided by the VCO2, and it shows how much ventilation is needed to remove a given volume of carbon dioxide from the body. And we use the nadir of VE VCO2 as a marker of peak ventilatory efficiency. And we use that nadir instead of the nadir for VE VO2 because it's more specific to the lungs and less complicated by O2 extraction issues in the peripheries. Now, the ventilatory equivalents both drop, like I talked about in a previous video, and that is because there is improvement in efficiency, and that is through 1, an increase in tidal volume, and 2, a reduction in areas of high VQ mismatching because there's more recruitment of pulmonary capillaries. So here you can see where we have that nadir of VE VCO2. And lastly, we can look for the partial pressures of end-tidal CO2. So end-tidal CO2 is typically low when dead space is high. However, end-tidal CO2 is also low when arterial PCO2 is low. So identifying the cause of a low end-tidal CO2 requires determining arterial values.